Imagine one day waking up and your life has changed forever. You lose the ability to drive. You can no longer see the faces of your loved ones. You cannot watch a movie, cook a meal, or even see your food on the plate in front of you. These are a few of the issues mature adults living with age-related macular degeneration dread happening, but are very aware of its possibility. They enjoy their everyday lives, but in the back of their minds wonder if today will be the day that everything changes. My name is Jennifer Martinez, and today I will be briefly discussing past, present, and future treatments for macular degeneration. You might be asking yourself, what is macular degeneration? Macular degeneration, also known as simply AMD, is an ocular disease that is the leading cause of irreversible vision loss in mature adults over the age of 60. It affects the light-sensing cells located in the back of the eye known as the retina, and specifically targeted in the macula. These cells sense the light as it enters the eye, records the images we see, and sends them via the optic nerve from the eye to the brain and produce sharp central vision. Macular degeneration happens when those cells become damaged, and as a result, the brain receives images that might be distorted or unclear. It may not noticeably affect your vision initially, but if it worsens, you may begin to notice an area of dark, wavy, or blurred vision that can increase in size over time, leading to eventual complete central vision loss. There are two basic types of macular degeneration. Dry macular degeneration is the more common type. It develops when the tissue of the macula, which is the area responsible for central vision, becomes thin and stops working the way it's supposed to. Dry AMD is the milder form and is usually not associated with much vision loss. Wet macular degeneration is the less common and happens when abnormal blood vessels begin to grow in the eye and leak serous fluid and blood under and into the macula, ultimately causing a blinding disciform scar. Wet AMD is the more advanced form that usually contributes significantly to progressive vision loss over time. Along with the two types of AMD, there are three stages of severity: early, intermediate, and late. Most people do not experience any vision loss in the early or even intermediate stages. In the late stage of AMD, vision loss has become much more noticeable. It is estimated that 30 to 50 million people are affected worldwide, and macular degeneration is currently affecting more than 10 million Americans. That's more than cataracts and glaucoma combined. According to the American Macular Degeneration Foundation, approximately 85 to 90% of diagnosed macular degeneration cases are the dry type, while 10 to 15% are the wet type. The biggest risk factor for macular degeneration is age. Your risk increases as you age and is most likely to occur after the age of 55. But age is not the only thing to consider when thinking of the risk associated with the disease. Genetics, race, gender, diet, and environmental factors also play a significant role in the development of macular degeneration. Things such as skin color, eye color, and the intake of certain vitamins can play a role in the development or progression of the disease. It has been found that genetic variants of two gene regions together account for approximately 40 to 60% of genetic risk in Caucasians. Those with a family history of AMD are at a higher risk. Studies have shown that Caucasians are more likely to develop the disease than African Americans or Hispanics. More so if you are Caucasian with blue or hazel-colored eyes. Technology advancements have enabled a large understanding of genetic accountability in AMD, but overall genetic basis for this disease is only partially understood. There is still a very large portion that is not able to be explained. When considering gender as a risk, there is no data supporting one gender over the other when it comes to early AMD, but when considering advanced or wet AMD, some evidence points to a higher rate in women over men. Environmental factors such as cigarette smoking increase your risk of development. A study done by William Kristen showed that current 1 pack a day or more smokers had a 46% increased risk. Current less than 1 pack a day smokers have a 26% increased risk. And past former smokers have a 30% increased risk compared to non-smokers. When you hear the word diet, you tend to associate that with weight-related issues. In this case, diet is associated with your eye health. Who knew, right? In a study conducted in Norway, dietary intake of antioxidants and risks of age-related macular degeneration, high doses of supplements with beta-carotene, vitamin C, vitamin E, and zinc were shown to slow the progression of dry AMD, a reduced risk of 35% with the intake of all 4 of the nutrients over an 8-year period. But changing your diet isn't the only way to get these benefits. Don't worry, for all of you who don't really want to eat the strict diet, you can look to AREDS, also known as age-related eye disease study. They are supplements in pill form that are taken daily to provide the vitamins and minerals shown to slow the progression of dry AMD by 25% over a 5-year period. A new study has shown that even a diet containing green leafy vegetables such as kale, spinach, and broccoli could help reduce your risk of developing early AMD. Though there is currently no known cure for macular degeneration, there are things you can do to reduce your risk and possibly slow down the progression once you've been diagnosed. For example, you can pursue a lifestyle change like changing your diet, including exercise in your routine, avoid smoking, and protect your eyes from UV light. Whilst almost no therapy restores normal visual acuity, any significant visual improvement may be regarded as beneficial. The treatment benefits for AMD are small. This is why there's an urgent need for new therapies. Looking back at the past treatments for AMD, you will find that there was no treatment until the 1980s. The use of laser photocoagulation was the first to become FDA approved for the treatment of AMD. It was used to target and coagulate newly grown blood vessels in the macula. And at best, laser photocoagulation slowed down the visual loss that eventually would progress to the complete loss of central vision. The main reason for this is the fact that thermal laser treatment coagulates new choroidal vessels at the cost of destroying nearby retinal cells and does not prevent reoccurrences. So they could treat your blood vessels, but not stop them from coming back, and in the process damage the healthy ones. The more laser scars in the back of the eye, the less vision you have. The other treatment for AMD was FDA approved in 2000, is known as photodynamic therapy, or PDT, combined with Visidyne. PDT is based on the release of a singlet oxygen species of verteporfin, which is injected into the bloodstream, and it's light activated. These highly reactive oxygen molecules damage the choroidal neovascular endothelium and lead to the coagulation of the subretinal choroidal network. Due to this non-thermal nature process, collateral damage to the adjacent retinal tissue is theoretically avoided. However, occasional damage to the retina or the choroidal vessels was reported. These treatments were not ideal as they eventually led to vision loss from both the disease itself and the secondary effects of the treatment. Today, laser treatments are still used in the treatment of peripheral vessels, which is away from the area that can cause vision loss. When looking at current treatments, though the first recorded use of an intraocular injection was in 1911 for the repair of a detached retina, it is currently the most commonly used treatment for wet AMD. The 3 most common medications are Avastin, Lucentis, and Eylea. Avastin and Lucentis are considered anti-VEGF medications. VEGF is short for vascular endothelial growth factor, which is responsible for the growth of the unwanted blood vessels, besides playing a role in the normal vascular growth. Anti-VEGF agents block the VEGF molecules and thus benefiting the patient by decreasing the abnormal blood vessel formation. This leads to stabilization in the vision and in some cases can even improve the vision. Avastin was originally FDA approved in 2004 for the treatment of colon cancer and is currently approved for other cancers such as breast cancer, lung cancer, and brain cancer. Retina specialists at the University of Miami were the first to experiment with the Avastin for wet AMD with a promising result. Avastin binds directly to the VEGF to form a protein complex to block it from further binding to other VEGF receptor sites. To this day, Avastin is not FDA approved for the treatment of AMD, but it's used regularly by retina specialists as off-label with promising results and very little adverse reactions. The cost of a dose of Avastin is around $45. Lucentis is a monoclonal antibody fragment derived from the same parent mouse as Avastin. It has been affinity matured to provide stronger binding to the VEGF-A. Lucentis was FDA approved for the treatment of wet AMD in 2006, and the cost for a dose is around $1,500. Studies have shown that when compared to Avastin, the only difference lies in that Lucentis has a reduced chance of an adverse reaction. Visual acuities were comparable. Eylea was FDA approved in 2011 for the treatment of wet AMD. It differs from the other treatments in that it's not a VEGF blocker. Instead, it's a fusion protein that consists of VEGF molecule receptors, thereby binding to and then blocking the VEGF. Eylea is the newest drug and used primarily when patients do not respond well to Avastin or Lucentis. It has a longer lasting effect, but visual results are no different from that of Avastin or Lucentis. The cost for a dose of Eylea is around $2,000. When considering these treatments, though, it's important to note that you cannot get just one injection and expect results. It will take a series of injections over an unknown amount of time to stop the advancement of blood vessel growth, and in some cases will be needed for the rest of your life. Since almost all treatments have not been directed at restoring lost vision, we are looking to the technology as the future of AMD. Most of the advancements have been in the creation of mechanical devices that allow vision restoration for those that have lost it to AMD. Here are a few of the devices that are in clinical trials for FDA approval or have recently received approval. Bionic eye. Surgeons at Manchester and Moorfield say they made history in 2009 by delivering the world's first trial of the Argus 2 bionic eye implants. The Argus 2 actually received FDA approval in 2013, but it wasn't until 2015 that Professor Stenga performed the first ever bionic implant on a patient with AMD. The Argus 2 retinal prosthesis is a medical device that is surgically implanted into one eye only and delivers electrical stimulation to the retina. It is intended to produce a useful form of artificial vision to blind people, stimulating remaining viable retinal cells to induce visual perception. It works by converting images captured by a miniature video camera mounted on glasses into a series of small pulses of energy, which are transmitted wirelessly to an array of electrodes that's implanted on the surface of the retina. These pulses stimulate the retina's remaining cells, enabling perception of patterns of light in the brain. Through help vision rehabilitation, the user learns how to interpret these visual patterns to regain some visual function. The cost for the Argus 2 system is approximately $150,000. After completing a 5-year testing period, the FDA approved the Implantable Miniature Telescope, or IMT, in 2010. IMT is a new patient care system that treats end-stage AMD. The device consists of an actual telescope that's the size of a pea, and it's designed to improve visual acuity by reducing the impact of the central blind spot caused by AMD. During surgery, the natural lens of the eye is removed, and the telescope is inserted in place of it. Light entering the eye is enlarged 3 times as it passes through the telescope into the eye. The result is improved vision because the image is larger when it reaches the cells in the macula. The actual damage in the macula cannot be repaired using this procedure, but the goal is to help the eye use the healthy parts of the retina to compensate for the damaged cells. The cost of the device alone is approximately $15,000. The Prima system consists of a miniaturized and totally wireless subretinal implant chip. This measures around 2 by 2 millimeters, special eyeglasses, and a small portable pocket computer. The eyeglasses have a miniaturized camera that captures information from the outside world and sends it to the computer worn by the patient. The computer processes the information and communicates it back to the glasses, which then transmits it through the eye via infrared light to the implant. The chip converts the light into electrical impulses in the retina that are sent to the brain. The patient learns to interpret these impulses through training and device tuning after the chip is implanted. While this is not the only retinal implant being developed, Prima differs from existing technologies in dramatic ways, such as it being completely wireless and having more electrodes than other implants, which is expected to vastly improve what the patient is able to see after the training. Prima received FDA approval to begin clinical trials in January of 2019. There is still a lot of unknowns about macular degeneration, how it's developed, how we can prevent it, but hopefully the day will come when our eyes are opened to the possibility of a cure. Thank you.